Hi, I am Dr. Felice Gersh, your integrative OBGYN physician. Today, I'm going to talk with you about cholesterol and the most commonly used drugs to treat high cholesterol, the family of drugs called statins. And statins are not one drug. As I said, it's a family of drugs, and we'll come back to that. The main differences between them is their potencies, and that does have some effect. So let's cover a little bit about cholesterol. So cholesterol comes 90% from the liver. 90% of all the circulating cholesterol is manufactured in the liver. Well, where does the other 10% come from? From food. But of course, there's an indirect effect of food and other things that can affect how the liver produces cholesterol. So why do we want to have cholesterol, or is it all evil? Well, it's not by accident that the liver makes cholesterol. It's because we do need cholesterol. Cholesterol is like a waxy substance. So it's not the same as fat. It's like a wax, okay? So it's very important for creating cell membranes, steroid hormones, the brain. So we do want to have cholesterol. It's really important in terms of, like I mentioned, the steroid type of hormones. What are those? Like cortisol. Cortisol is essential for life. In fact, it's the only hormone that if you don't have any in 24 hours, you will die. So, of course, we need cholesterol. Cholesterol is the foundation for the creation of testosterone, estrogens, progesterone, all the steroid hormones, all the androgens like DHEAS, DHEA, they all come from cholesterol. But like everything in the body, it can be altered in ways that can create harm. Isn't that amazing that things that are really good can be modified to create harm? Like what's another example? Inflammation. So inflammation, you've heard me talk about so much because we have to be able to create inflammation, or how would we deal with infections, pathogens getting into our body, injuries from accidents, bleeding, and running for your life from some wild animal. So we do need to have inflammation, but uncontrolled inflammation is really terrible for our health. Well, cholesterol is essential. It's very good. But if you have too much cholesterol, anything that's really good, too much of can make it bad. Or it can be modified. What if it becomes oxidized? So I used to say, and now I will not, because I was corrected, and I stand corrected, that I would equate having oxidation of cholesterol with like rancid cholesterol. Well, it turns out that there's a very specific definition for something going rancid. It applies to actually oxidation of specific types of fats to create sort of that yucky smell, like, rancid oils. So it's a specific type of process that applies to certain fats. So I won't use that term anymore. So I went to look up synonyms so you could get an idea of what does it mean to have oxidized cholesterol, and often referred to as oxidized LDL, low density lipoprotein cholesterol. We'll touch on that too. So we know that we can get cholesterol turning bad. So oxidized, but a lot of people don't know what is oxidation. So the best analogy I came up with, see what you think of this one, is rusting. So if you take oxygen from the air and water and mix it with iron, you can create rust. That's a process of oxidation. So we're not really rusting, okay? But it's just a process involving electrons, and it's like physics, so we don't really want to get into that. But just know that oxidation is generally undesirable, especially when it comes to in your body or your metal, wrought iron metal furniture. We don't want them to rust either. So when you get oxidation or this alteration in a negative way of cholesterol, and I'll talk about how that can happen, then it opens the door to creating plaque, atherosclerosis. So the bottom line is we want cholesterol, but we don't want it to be oxidized, and we don't want too much of it. So how can you make too much cholesterol? Why would you make too much cholesterol? Well, there are certain things that can affect the liver's production of cholesterol. A big one that affects virtually all women is called menopause. Yes, estradiol, my favorite hormone, is critically important for regulating the production of cholesterol in the liver. And virtually all women will have an elevation. It's not a question of if, it's how much of their production of cholesterol in their liver as their estrogen production from their ovaries drops. So I have patients all the time, they say, I always had excellent cholesterol, even on the low side. And now that I'm in menopause, look, my cholesterol is really high. And it's like, no surprise to me. So part of that is the production. The other part is the elimination of cholesterol. So what happens after you release cholesterol into the bloodstream? Well, it's supposed to go to the target where it's needed. And then eventually it's supposed to be picked up and brought back to the liver for disposal. Well, it turns out that there are certain types of, I'll call them envelopes. They're called apolipoproteins. These are also made in the liver, and they carry cholesterol to wherever it's supposed to go, and there's different types. So these are called apolipoproteins. Now, think of the mail. We're going a little bit, retro here because a lot of people don't write letters. But let's say you were going to write thank you notes, okay, or send out Christmas cards or, some kind of notification or write a check, because you're old-fashioned like me. So you write up whatever it is, and then you can't just take that and drop it in a mailbox. That's not going to happen. You're not going to get it where it needs to go. You have to put it in an envelope. You have to address it and seal it, and you have to put on a stamp, okay? Well, a similar thing happens in the body. The liver makes cholesterol, but it can't just drop it in the blood. That would not work. It needs an envelope. And as I mentioned, these are called apolipoproteins. The one that takes the cholesterol from the liver and delivers it to wherever it's needed in the body, those are called apolipoprotein B. Now, if you measure, which I do all the time, your level of apolipoprotein B, you would like it to be no more than 90. That would be optimal, under 90. So more than that means you're probably making more cholesterol than your body really needs. So anyway, you make this apolipoprotein B, and the cholesterol gets in it, and then it goes around the body. Now, old cholesterol needs to be picked up and taken back to the liver for disposal. The envelope that does that, that's called apolipoprotein A1, also known as reverse cholesterol, and that is part of HDL, which some people have called, but I don't like to use these terms, good cholesterol, high-density lipoprotein, and other people have called LDL. And by the way, LDL is under the umbrella, the apolipoprotein B, which I told you takes cholesterol made in the liver and then transports it, and that's the envelope. That is part of LDL. So ApoB is part of LDL, ApoA1 is part of HDL. But they're not really good and bad cholesterol. They're just doing different things. What is bad cholesterol? Bad cholesterol is oxidized cholesterol, rusted. Just think of like human equivalent of rusting, okay? But, using a little artistic license there. Okay, so you have apolipoprotein A1 carrying cholesterol back to the liver. In the liver are specific receptors. So it's like, think of it as a spaceship docking. So you have the ApoA1 that has this cholesterol, this old cholesterol, and it comes and it's like a spaceship docking onto the liver onto the receptors called the LDL receptors, and then the cholesterol that's in this envelope gets into the liver processes it, it goes out the bile duct, and then it goes into the intestine. It may end up first going into the gallbladder, which can store cholesterol, but eventually the gallbladder should contract and it gets into the intestine. And I'll tell you in a minute what happens when it gets in there and what you can do, because ultimately this is about understanding for the purpose of what to do, because we don't just want to have information for its own sake, although that's kind of nice, but we want to know what to do with this information. So what happens in menopause when you have estradiol not around because you're not making it anymore? The LDL receptors, they decline in their number. So that is not good. So you have fewer of these receptors, they're not working right. So you do not have proper LDL receptor function in the liver to pull the old cholesterol out. So that can end up giving you a higher number of total cholesterol and a higher amount of LDL cholesterol because you're not so good at getting it out, plus your liver is making more. So that's a double whammy. Now, what about the oxidized cholesterol? So oxidized cholesterol is not good. So we have immune cells that circulate in the blood. One type is called a macrophage. Macrophages are like the gobblers. They have this amazing process called phagocytosis. It literally envelops and gobbles up pathogens or damaged tissue. The pathogens we call the PAMPs for pathogenic tissue that is attracts the macrophages, and the DAMPs, the damaged tissue. So this could include oxidized bad cholesterol. So it's not the cholesterol made by the liver, it's the liver's production of cholesterol, which becomes bad through this process of oxidation, which is related to inflammation. So what you have now is oxidized cholesterol in these envelopes. Well, we'll call them oxidized LDL. Well, guess what? You have a reduced number and function of your LDL receptors in your liver to pull this old stuff out, and like the spaceship docking ports, they do not recognize oxidized LDL. They do not. So now these envelopes cannot get back onto the docking sites in the liver and get pulled out. So not only do you have more difficulty getting LDL cholesterol out that's not oxidized, but once it's oxidized, it doesn't get recognized by the receptors, so you can't pull it out. But it is recognized as the DAMPs, the damaged tissue, by the macrophage. So the macrophage comes and does phagocytosis and gobbles up this rancid, I'm not going to say that again, oxidized cholesterol. So now you end up with all these macrophages. They're still circulating in the blood. They still have the ability to be attracted to damage because damage puts out signals called damage signals. The macrophages are attracted like a magnet to pathogens and damage. So now you have these macrophages circulating around and they're gobbling up more and more of this oxidized LDL cholesterol. And now it looks funny when you look at them under a microscope. They look like they're full of soap suds because that's what oxidized cholesterol looks like. It looks like soap suds when it's gobbled up by the macrophages. So someone came up with this clever little term, macrophages that are full of this oxidized cholesterol, this LDL cholesterol. They call them foam cells because they look like they're full of studs. Now, they're still functioning macrophages. What if you have damage, injury to the lining of the artery wall? Remember, the blood is flowing inside the lumen, and there you have it's surrounded by the lining. The lining is called the intima. If you have damaged intima, it puts out damaged signals, just like any other tissue in the body. So the macrophages hone in and like a magnet go right over and they line up along the damaged intima. Well, if you have cracks and fissures, then they can work, some of them work their way through these cracks and fissures into the inside wall of the artery, where they create more damage, creating more inflammation, more injured tissue, attracting more macrophages, carrying more of this oxidized cholesterol. And before you know it, what does the inside of your artery turn into? Like a garbage dump full of this junk. And it can be very pro-inflammatory. And these immune cells, they make types of enzymes like myeloperoxidase and LPPLA2. These are enzymes that we can measure in the blood. When they're high, it means that there's probably inflammation in the artery wall. And that's a sign that the plaque can become unstable and then rupture, releasing this garbage content and creating more problems, pro-coagulation and causing more blood clotting, and creating a little clot that, if it comes off, can then travel downstream, get lodged where the artery is narrowest, and create a stroke or a heart attack. That is not the only way that a woman can get a heart attack, but it is one way. So it all started with oxidation of cholesterol, having that cholesterol go bad due to inflammation. So it wasn't the cholesterol's fault. It was the lack of adequate estrogen, plus often, and that's in menopause, of course, but often poor lifestyle choices, environmental pollution, smoking, and chronic stress can all contribute to all of these things, creating inflammation. But we'll talk much more about how you can have inflammation in your body another time. But back to the story of cholesterol. So we don't really have HDL is good cholesterol, LDL is bad. That's simplistic thinking. Let's rethink it. The cholesterol is inherently good. It becomes bad if you make too much, if it becomes oxidized, okay? Now, we have the reverse cholesterol, the apolipoprotein A1, which is part of HDL, which returns, in appropriate situation, returns the old cholesterol to the liver for elimination. So, of course, that's good, but the cholesterol made in the liver, which includes LDL, isn't bad. It's only when it gets oxidized, okay? So it's really, really important that you know that cholesterol made in the liver is not inherently bad, okay? What happens if you don't have enough LDL cholesterol? You don't have enough cholesterol. Cholesterol not only does all the other things I mentioned, but LDL cholesterol is linked to proper immune function. So you really don't want to not have any, but you don't want it to be oxidized, and you don't want to go over the top making too much. So what if you do have a lot of oxidized cholesterol? And what if you do have really high cholesterol? So what should you do about it? Well, if you are a woman and you're in menopause, one possibility is to go on hormones. Realistically, we do not have a lot of data. We know what happens over and over if you don't have enough estrogen, but we lack a lot of clinical data because no one's doing the studies on what happens. I can tell you in my observation, you get improvement, okay? But that would not be the only thing that we would want to do. Now, one more word about oxidation. It turns out that there's an enzyme called peroxidase 1, also known as PON, P-O-N-1. That enzyme helps to prevent oxidation of LDL cholesterol. Well, guess what? No surprise. Oxidation of LDL cholesterol and PON1 is modulated by estradiol. Always estradiol in some way is involved. So that is really, really important to know. That when you lose your adequate levels of estradiol, not only do you make too much cholesterol, you can't get it out of the blood to get it eliminated, but you are also more prone to creating oxidation of cholesterol. So you have like everything seems to go a little bit awry. Well, what are we going to do? Once again, one thing is to try to get the cholesterol that is getting out of your liver into the intestines, to get it out of the body. How do you do that? You want to eliminate it with a bowel movement. You want to eliminate it with the stool. Now, if you do not have a high fiber diet that has binders in it that bind to the cholesterol, then you can actually reabsorb the cholesterol. There's a recycling system in the body where you can actually pull the cholesterol back in. That is one reason why oats, by the way, I'm a big fan of oats, but not instant oats, please. Try to get organic. And for me, I do gluten-free, but you don't have to if you don't have a gluten problem. And you can get slow-cooked rolled oats, steel-cut oats, or oat groats. Oat groats are the most fibrous, down to less and less when you get to the rolled oats. But rolled oats, too, will lower cholesterol. That's why oats, when you get it, it has the little American Heart Association heart as a heart-healthy food because it acts as a binder. It binds cholesterol in the intestinal tract so that you will not reabsorb it. And there are plants that actually also have binders in them called stanols. So you really want to eat a lot of plants, a lot of fiber. It will help with binders. Now, there have been drugs that actually act as binders that were prescribed for quite a while to lower cholesterol, but that didn't work for when you take it as a drug. But if you take it as a food, it's very good. In fact, vegans who are eating not processed vegan food, but plant-based vegan food, they have typically very low cholesterol. In fact, sometimes I have to say, oh my gosh, your cholesterol is too low. Can you please eat like a little bit of organic butter? Just a little bit, or maybe because it's really hard to get vegans to eat anything but vegan food. So sometimes I just say maybe have a little bit of coconut oil, which is kind of like a saturated fat, because you need to have a little bit of cholesterol. Remember, 10% of the cholesterol we have is from the food we eat. But the vegans that are eating these really high fiber plant-based diets filled with lots of binder type foods. Another really good binder are the legumes, the different beans. Beans are great binders. They will lower your cholesterol. So by eating a high vegan diet, or if you do vegan plus, where you have a little bit of animal, this is amazing to lower cholesterol. It is not accessed enough as a tool. So most women, even though they're not making estrogen, if they eat loads and loads of plants, like 9 cups a day with lots of beans, and the steel-cut oats or the rolled oats or oat groats and other whole ancient grains, their cholesterol will come down. So think about that, adding that into your diet. And when you have all of those vegetables with all of their antioxidants and phytoestrogens, it will also help to lower inflammation and thereby lower oxidation. So this is very helpful. So I can put patients on a plant-based diet with like 3 cups of vegetables, a cup of fruit at every meal, lots of bean, legumes, and ancient grains, and their cholesterol will come down very well over 6 months. What else can naturally lower cholesterol? Exercise. It's amazing how exercise can help lower cholesterol. So please, you want to do both resistance training but aerobic exercise to help naturally lower your cholesterol. What else? Stress. Lowering and controlling stress. Stress will increase your cholesterol. So whatever mind-body practice you like, that is a good way to go. There's tapping, there's progressive relaxation, there's guided imagery with or without biofeedback to monitor heart rate variability, all different kinds of meditation. You can just do prayer meditation if you're so inclined, but you need to do something. You can get a vagus nerve stimulator. You want to increase vagal tone and lower stress. I love laughter yoga. So Google that if you have time and interest. Laughing will help lower stress, even if you fake the laugh, okay? So we've got to work on stress, and don't forget sleep. So basically, all of that. Now, as well, heavy metals like mercury, lead, arsenic, cadmium, those are terrible. You know what has a lot of cadmium? Smoking. So smoking is terrible for creating oxidation and increasing atherosclerosis. So of course we do not want that. But alcohol, eliminate alcohol, or at least as close to elimination as you can, because alcohol is terrible for your cardiovascular system and it will increase cholesterol. So getting rid of smoking and getting an air purifier, a water purifier, making good choices, avoiding ultra-processed food, complex carbs are the way to go. They're great, but processed carbs and sugar, high fructose corn syrup, terrible. They will increase your cholesterol. Work to get to an optimal weight, because excessive adipose tissue creates inflammation, and that will also lead to increased stress and increased cholesterol production. So these are some of the natural ways. What about supplements? Almost everyone now has heard of berberine. Probably berberine's mechanism is through the gut microbiome, because I haven't mentioned that yet, but the gut microbiome, when you have problems with it, it will cause the liver to become also inflamed. They're very connected, the gut and the liver. And then when you have the wrong gut microbiome, you're going to have a more inflamed liver. The liver is going to produce too much cholesterol. You're going to have a lot of inflammation as the endotoxins from inside the gut leak out between the cells of the lining, called impaired gut barrier and leaky gut. That creates more inflammation, insulin resistance, metabolic dysfunction, more cholesterol, more oxidized cholesterol, more plaque, more risk of heart attack and stroke. So we don't want that, of course. So everything we can do to improve the gut microbiome will be very helpful. That gets back to our diet and stress, and there are certain supplements, one of which happens to be berberine. Berberine is actually an antimicrobial, and it will help kill bad bacteria in the gut. So that is very helpful. Now, what about when you talk about bergamot? So I don't know if you've heard of bergamot. It's a Mediterranean citrus fruit, which has actual published studies showing that it can help lower cholesterol. So I do use that in cases where the cholesterol is a little bit elevated and patients don't want to go into statins, and we'll talk about that in a moment. They want to try natural ways to lower cholesterol, which, by the way, is the standard of care, is to try to do it naturally. And we're talking here about primary prevention. I'll talk about secondary prevention another day. Primary prevention means someone has not had a heart attack or a stroke, because that would be called secondary prevention, so they don't have a second episode. So we're talking about primary prevention here with everything I'm talking about. So we don't want to initiate a drug treatment until we've tried lifestyle first for up to 6 months before we give up. And I try never to give up, but sometimes there is a point that we do give up, but that doesn't mean that we can't go back, and even if someone went on a drug, that we can't take them off of the drug. So bergamot can be helpful. It's not going to lower an extremely high cholesterol. We're also not talking about familial hypercholesterolemia, which is relatively rare, and that's a genetic disorder that causes really high cholesterol. Those people have to be treated with drugs. Usually Repatha, that's a different type of drug. We'll talk about that another time, because those people have phenomenally high cholesterol. So that's a different problem. That's not lifestyle, that's genetic. So let's get into statins for a minute. So statins work by preventing the proper function of a certain enzyme that's in the liver. Well, interestingly enough, it turns out that estradiol modulates the function of that enzyme. That's why when you lose your estradiol, you don't have proper control of that enzyme. And that enzyme, if you have it activated, will actually decrease the production of cholesterol. But without estradiol, that particular enzyme is not properly controlled. So statins, to a significant but not a complete degree, of course, because you need to have some cholesterol, but it down-regulates that enzyme so that you can't make the cholesterol the way you normally would. And if someone is an overproducer, this will help lower their production. The problem, in some cases, is that that enzyme has another end product. It's also the enzyme that helps the body to create coenzyme Q10. So that's a critical coenzyme that works in the mitochondria along the electron transport chain to create energy, where you need energy everywhere, of course. So that's one of the concerns. You need energy in muscle, so that's one of the reasons why one of the side effects of statins is muscle pain. And in fact, a very high dose of a type of statin, I told you it's a family of drugs called simvastatin, the brand name Zocor, the highest dose of that, which at the time was 80 milligrams a day, it was taken off the market for general use because it worked too well at blocking that enzyme, and CoQ10 levels went so low that people actually had a higher risk of heart failure because the heart could not create enough energy. And now this may be why there's some difference, and women tend to have more muscle pain, is because estradiol regulates mitochondrial function. And of course, if you're in menopause and you're not on any estrogen therapy, you will have decrease in your functionality of your mitochondria, and then you add in a drug that blocks to some degree the production of a critical coenzyme for mitochondrial energy production, and hence you can end up with muscle pain, and in that case of that very high dose, actual heart failure, because the heart is a muscle. But what about other doses in other situations? So the most potent of the statins on the market is called rovastatin, and it's very commonly used now. Earlier statins like pravastatin, that is a much weaker statin. And then there's atorvastatin, that's in between, okay? And you can give low-dose statins, you can give high-dose statins, and there is some difference between males and females. For primary prevention, we don't know for sure. I actually did a little bit of a literature search on this, and there's mixed data. There is mixed data on whether there is a significant benefit of use of statins for primary, remember, preventing a heart attack or stroke in women who have yet to have one, hopefully never will. For secondary prevention, there seems that there is a statistical benefit. So it is very reasonable, if a woman has had a heart attack or stroke, to go on a statin under the care of an internist or a cardiologist, someone who specializes in this. For primary prevention, there are studies. They're not proactive, like double-blind placebo control. They're more like looking at data that's in registries and so on, like in Scandinavian countries where they have these big registries that do look like there is benefit for primary prevention in women who have other conditions, like, say, hypertension. So, and then there's other studies that look at data, and they say there is no statistical difference in the women who do or don't go on statins. So what would be the harm of going on a statin anyway? For most people, if they don't have muscle pain and they are feeling okay, there probably isn't a huge risk to go on a statin. So what about the diabetes? That's the one I really have to mention. Women are not the same as men, and now we have data. There was a big analysis from the Women's Health Initiative that I usually talk against, but some of the offshoot studies are actually useful. And it showed, and other studies show other degrees of risk, that women who are on statins will have an increased risk of developing diabetes by 71%. So that's really high. So if a woman goes on a statin, they absolutely must be monitored closely to see if they're the ones that develop diabetes. Because it's not like 100%. Not at all. But women need to be monitored. That's like critical. If a woman goes on a statin, she needs to be monitored to see what happens to her glucose regulation. And then if she does start having insulin resistance heading towards diabetes, everything needs to be reevaluated. Everything in medicine is about risk-benefit ratio. The benefit had better outweigh the risk in every case. Now, what about the risk of dementia? Well, that's another question that is not really answered. We don't know. There was concern that if you're on a drug like a statin, then you are going to lower your CoQ10, lower your ability to make energy in your brain. Well, we just don't really know because there's so many influences on the brain. How do we separate them out? There's no prospective double-blind study. So I can't say it is, and I can't say it isn't a risk. But what I can say is, to me, if you have high cholesterol and you're a woman, look at going on hormone therapy and doing all the lifestyle things first. But if you can't get it down, you really need to weigh the risks and benefits. And in your case, it could go either way, but maybe the benefits are in favor of going on a statin. What could be a deal breaker, like to make a decision, actually? Well, I like to look at the arteries. So there are ways to look at arteries. For example, you can use ultrasounds and you could look at the intima. You can look at how much plaque. And when it's really questionable, you can do a CT coronary angiogram, which will help you with AI interpretation because it's really hard for radiologists. AI actually works well looking at these studies to see if you have vulnerable plaque. Because interestingly, one of the main ways that statins actually lower the risk of a heart attack or stroke isn't by lowering cholesterol. It turns out it's by stabilizing plaque. This is a completely unexpected benefit, and this may be why it helps at all, more than any other thing. It is by helping to stabilize plaque. So if you do a CT coronary angiogram because you have a lot of plaque and really high cholesterol, you've tried lifestyle and you're trying to decide, should I go on a statin, not go on a statin, is it worth it? Pros and cons. You can get this test, by the way, usually not covered by insurance, and you can see if you have risky plaque, vulnerable plaque, soft plaque, and that can help make the determination whether to go on a statin or not. There are other drugs that can help with lowering cholesterol to some degree, like Zetia and Repatha. They're drugs I'll talk about another time that can be additive or replace taking a statin as far as like Repatha goes. They work by different mechanisms. So the bottom line is cholesterol is good, but oxidized cholesterol is bad. We want to lower our risk of oxidation by doing all the lifestyle things right, eating lots of vegetables, lots of soluble fiber, binders, and taking hormones if you're a woman so that you can naturally activate the mechanisms in the body that estradiol control to control the production and elimination of cholesterol and to prevent or reduce the risk of oxidation of cholesterol, which is what gets carried in those macrophages that gobble it up as damaged tissue and carry it inside the walls of the arteries, creating potentially vulnerable plaque that can be life-threatening. So I know this is a lot of information, but I hope it's helpful to understand cholesterol, your body, and statins. Statins are not evil. They're far from perfect. They may be the right choice in some, but always try lifestyle first and talk to your own healthcare caregivers to decide what's right for you.